also talking a little bit about the delivery of medical care for people with epilepsy during COVID-19 pandemic. So these are my disclosures, so there's nothing relevant for this talk. A few words about coronaviruses in general. So these are a family of viruses with a single-stranded RNA genome, and they have significant genetic variability. That means that they are very capable of mutation, rapid mutation at a higher rate. So they have a higher recombination rate, and they can be easily distributed among humans and animals and cross-species contamination as well. Numerous coronaviruses have existed through human life and animal populations without causing any life-threatening illnesses, and I've just listed a bunch of them that are causing common flu sometimes. The genetic recombination of viruses within random intermediate hosts can produce contagious strains that are highly pathogenic to humans. And SARS-CoV-2, which is the virus that causes COVID-19, is genetically and structurally related to SARS-CoV family, which are unique, which is unique among this group in being contagious with a rapid spread. And so these are the novel coronaviruses of 21st century. There are three of them that I highlighted. The one that we are talking about, the severe acute respiratory syndrome coronavirus, or SARS-CoV. Actually, this one is the one that caused the original SARS in 2003, and the intermediate host was masked palm civet. And the second one was Middle East respiratory syndrome from Saudi Arabia, and labeled as MERS-CoV in 2012. From dromedary camels as being the intermediate host, and the current virus called SARS-CoV-2, which started, the first case that was identified was atypical pneumonia from a cluster of patients in Wuhan city in Hubei province, China, on December 31st, 2019. And the intermediate host has been labeled as Malayan pangolin, and the host of these, the natural reservoir is horseshoe bats. So this is just a picturesque view of what I just mentioned. So this is the SARS that we dealt with in 2003. That's the Middle East version that we talked about, camels being the intermediaries. And that's the civet for the original SARS, also originated in China, and the current one from Wuhan with a pangolin that was smuggled to the wet market in Wuhan, and eventually they get to human. So coronavirus disease 2019, or COVID-19, is the official name of this disease. Initially, it was referred to as 2019 novel coronavirus, or some initially also was referred as Wuhan coronavirus. Subsequently, the virus was identified as severe acute respiratory syndrome coronavirus 2, or SARS-CoV-2. So that's the virus itself, and that came about on February 11, 2020 by WHO. And at the same time, a few hours later, WHO posted the official name of the condition, which is coronavirus 2019, or COVID-19. As I mentioned, the first reported case in human were from Wuhan in Hubei province of China on December 31st, and there has been a rapid spread since then. The very first case outside China was in Thailand on January 13th, so about 2 weeks later, and it has become a global problem since then, with WHO declaring it a global pandemic on March 11, 2020. This is on Sunday. I went to Hopkins University website. I highly recommend this website. It is highly accurate and also up to date in keeping track of the burden of the illness globally, and also you can look in this each country and region specifically. So this is as of Sunday, April 26th, and the data is just 24 hours old. shows the number of cases that are affected, and these are the countries. And currently, U.S. is leading the numbers in the number of infection and fatality. This is the same website for US, also looking at different cities. As you know, New York City and New York State has been hit the hardest. This is from our Canadian website, Government of Canada, and it shows again, same thing, dynamic, up-to-date, and showing the number of cases affected and number of fatalities in Canada. And as you can see, that pretty much most of our provinces are affected, except for one areas that have tried to manage to contain it. And this is from our own Middlesex County. And again, the numbers are being published and updated on a 24-hour basis. So if you wish to stay up to date, please visit these websites that are quite credible. I think it's worth talking a little bit about historical conditions. Spanish flu, also called 1918 flu pandemic, which was between January of 1918 and December of 1920. So it took about 36 months for it to die off. It's been estimated, these are not highly accurate because of World War I. There was some secrecy in publishing all the numbers at the time, but it's estimated that total number of people infected were 500 million. So that accounted for a third of the world population. And the death toll, again, varied between 17 to 50 million, and even some people estimate to be 100 million. And unusually, for the first time, this was the highest among the young adults, and that was unusual for most of the pandemics we had up to that time. And it is one of the deadliest pandemic in human history. So thank God that COVID-19 has not reached that stage. Early reports of illness and mortalities were censored due to the war, especially in Germany, UK, France, and US that were all participating in the war. The country that was neutral was Spain, and their journalisms were not censored. Therefore, newspapers were freely reporting on the impact of the illness on the country. In particular, they published the illness of King Alfonso the 13th. So it got the name Spanish flu, but that does not mean that it originated from there. In fact, the origin has been debated, has been labeled coming from China, Boston, Kansas City, or Australia, and still the jury is out on that. The viral infection was not particularly more aggressive. It was just the influenza strain, H1N1, that currently we call common flu. It is thought that the bacterial superinfection, when they had protracted illness, was the main cause of morbidity and mortality at that time, along with malnutrition, overcrowding medical camps and hospitals during the war, poor hygiene, and again, prolonged stay in the bed with infection after that. And we didn't have penicillin, obviously, those days. I highly recommend this movie. It's called Contagion, a thriller film that is available in Netflix. Matt Damon is one of the main characters in that, and he plays Mr. Emhoff, and Gwyneth Paltrow as his wife, and they have a son and a daughter. I do not want to give the plot away, so I will not spoil it for you. This gentleman is the investigative reporter, and these are CDC pandemic specialist, and this is the researcher that kind of, it's meant to be realistic. It is actually released in September of 2011, so it was way before the current pandemic came about, so that's what makes it more interesting. And it is shown that at some point Miss Emhoff develops seizures while she is in the hospital and eventually passes away from her illness. So certainly makes the movie more dramatic, but also highlights the importance of talking about this topic. One of the gentlemen who was the advisor to the to Mr. Stephen Solberg was Dr. Ian Lipkin. He's a neurologist, neurovirologist, and also has affiliation with the Department of Epidemiology in Columbia University. Uh, he was also an advisor to the government of China and, in original SARS, but as well as this current COVID-19 pandemic. In fact, he had a recent trip to China for providing advice to them, as well as to MERS for Saudi Arabia. In fact, when he was talking to the Fox News on March 23rd, he disclosed that he himself got the virus, and he believes that he did not get it from his own lab, or from the medical facility or China. And he thinks that it was a community spread, probably from numerous media interviews that he gives. There are also celebrities and other people that are affected with this condition. I listed some of them, so most of you know, or everyone knows, Tom Hanks and his wife, that they checked in the hospital in Australia and subsequently released. And I hear that currently they wanted to contribute their sera to potential discovery of treatment for the condition. But also many other people. Prince Charles had a very mild symptom. Boris Johnson was the head of state, prime minister in UK that got hospitalized and went to intensive care unit and doing well right now. Ron Paul is a Republican senator in US Senate that was first diagnosed with it. Prince Albert of Monaco had the disease as well. Our own Sophie Trudeau, the wife of our prime minister, eventually tested negative, but she had positive also. And the wife of the Prime Minister of Spain was affected. So is, most people know, Chris Cuomo and his right hand, Brooke Baldwin from CNN, that got the disease. And they tried to display what it is like to live with this virus. So that was interesting. So it affects rich, poor, powerful, weak, so there is no discrimination, and currently there is no effective therapy. Most people in the epilepsy community would recognize this young girl, a 13-year-old, unfortunately passed away on April 7, 2020. Her name is Charlotte, and most people know her from Charlotte Webb. And she made an impact not only in the US, but also globally by bringing to medical attention and media about the importance of using CBD oil in treatment of epilepsy. She had Dravet syndrome, a form of epilepsy syndrome that started at age 3 months for her. She was using the wheelchair because had difficulty with ambulating and had difficulty with communication when her illness was at its peak. And she took this CBD oil from these brothers in Colorado Springs that were developing highly pure or significantly high CBD oil with limited THC content that eventually bear her name on it. And her seizures went from 300 per week to 2 to 3 per month. Her communication improved, and she had a better quality of life. And anyone is interested, you can look at the CNN documentary by Dr. Sanjay Gupta with her from 2013 that she was featured in. It's called Read. She was hospitalized with pneumonia in April of 2020. During that illness, which was febrile illness, and it's typically known that Dravet syndrome can be exacerbated by fever, she had seizures, respiratory failure, and eventually cardiac arrest and died, unfortunately. She was initially tested negative on April 3rd, 2020, and then got readmitted, and the doctors presumed that she likely had COVID-19, but to my knowledge, it was not confirmed. But nonetheless, she has been labeled as COVID positive. So SARS-CoV-2 or COVID-19 virus genome, the entire genome of this virus was sequenced by the Center for Disease Control and Prevention in China, or their CDC. There's a lot of media and there's a lot of political rhetoric that's going on these days, but it's important in the scientific area we stay focused and kind of avoid those misinformation. The reality is that the Chinese government sequenced the entire genome of this condition by January 12 and posted it available for all the scientific community. The collaborations between the scientific community has been very strong, and the clinicians across the globe have been working together to combat this disease. Again, very different from how political finger pointing are going on. So these are just some description of the virus that has been very helpful. So I think we know what we are dealing with in terms of its genetic composition. You might have seen this picture often flashed in media. The important thing about this is that the virus has these also referred as the spikes. I know we use the word spike quite often in epilepsy, but these are the spikes of the envelope of the virus, and these are the ones that are used to penetrate the cells. And there are additional proteins there. There's the E envelope protein, membrane protein, and also there's a protein where the gene inside gets enveloped around it. It's called N protein. But the importance of the S protein, it is the one that allows this to be insert itself into the cells. This is meant to show the life cycle of the virus. I do not want to go over the details of this with you, but again, you have the spike at the surface that allows it to bind to the receptors. These are called ACE2 receptor, or angiotensin converting enzyme 2 receptors. And I'll mention that why that is important. But there are other hosts of cellular machinery that's employed by the virus to replicate itself. So it gets inside the cell and uses the different machinery, and eventually Golgi system, reticular reticular activating system, the ribosomes and things like that, basically use the cells organelles, or Golgi apparatus, and to replicate. And the point is that there are potential avenues for treatment at every stage. So you can block the entry here, you can block the replications and exocytosis and things like that. So there are lots of drugs that are potential targets in different areas, including the one that has been in media quite often, hydrochloroquine or hydroxychloroquine, but lots of antivirals. So it provides opportunity for potential therapeutic interventions at multiple levels that are currently being formally studied. These are some of the symptoms of the condition. So it's a respiratory illness, and cough, shortness of breath, rhinorrhea, and sore throat are the ones that are more commonly thought about, but also affects the gastrointestinal system. Nausea affects the sense of smell and taste, and we'll talk a little bit about that, why that's important, the loss of sense of taste, smell before even the respiratory symptoms. And also causes muscle fatigue, headaches, myalgia, and fever, obviously. Patients that develop pneumonia, they will have a characteristic abnormalities on their chest x-ray that are easy to diagnose, or either with chest x-ray or CT of the chest. In the blood, the white count tends to go down, platelet tends to go down, CRP rises, and D-dimer can also rise. And there are specific diagnostic tests in the nasal swab, as you know, that or antibodies to identify the virus. So the general guidance as far as this virus pandemic is that the important things that most people will develop in mild symptoms. I think that is at least partially reassuring, but it's not comforting, obviously. Some people may need to see a healthcare provider or be hospitalized, a small portion. And the aim is to slow down the spread of the virus, ensure people receive the care they need. Community mitigation is the critical thing, and that's the process of slowing down the spread of the virus. And it's important that we follow the guidance set by the World Health Organization and our health authorities in our own and officials in our own country and local health authorities. And these may vary from province to province, so that's important to keep that in mind. I did talk about that receptor that the spike binds to, and that was called ACE2. And this is just meant to show the distribution of these receptors. So it first in the virus that goes into the bloodstream, so it's called viremia, and through the bloodstream, and it goes to the different organs that has these receptors. They are present in neurons and glial cells that are in the brain, and in also endothelial or blood vessel wall. and also other organs. So lung itself has a lot of ACE2 receptors, kidneys, heart, gastrointestinal system, as well as testes also have these receptors. So these are all potential targets of the disease. And in fact, it is possible for some people to present just loss of smell and not much of respiratory symptoms, because the virus, instead of going downwards, can spread up from the nose through cranial nerve 1 to go to the brain. So that's how you can potentially get the sense of loss of sense of smell. So it is a virus that spreads mostly through respiratory droplets, as being a respiratory virus, and can travel 3 to 6 feet. And that's the reason for being away about 2 meters from other people, so social distancing. And also been discovered that it is a fomite transmission. That means that it can also transfer from the surfaces. And these are just some guidance for you that be aware of how long it can last in surfaces: 4 hours on copper, 24 hours on cardboard, 72 hours on plastic and stainless steel surfaces. And you probably followed the story of Diamond Princess cruise. And after all the passengers evacuated in Japan, the Japanese researchers were able to identify the RNA of the virus 17 days later in the cabin of symptomatic and asymptomatic passengers. So it's how long it can stick around, and that's kind of makes it difficult to eradicate. And as far as the airborne transmission, that also has, this one has an implications for patients going to the hospital, and why we ask people to stay away from the hospital as much as possible during this time, because of aerosol producing interventions, endotracheal intubations, bronchoscopy, suctioning, nebulizer treatment, non-invasive positive pressure ventilation, and delivery of oxygen through a high flow nasal cannula. So these are all means that the virus can spread and potentially also affect the healthcare providers as well. So these are high-risk procedures these days. So why do social distancing? In a fully susceptible population, the basic reproductive number, or RO, I'm going to come back to that, that's an important number, for SARS in China was estimated to be 2.38. So that means that one individual can spread the disease to 2 to 3 people. I know there are some super infector people that have been identified, but on average, one person can spread the disease to 2 to 3. And the RO number for seasonal flu is 1.5. If you wanted to eliminate the pandemic, you need to drop the RO to less than a 1. And the substantial transmission from asymptomatic hosts. So that's the critical thing, that some patients are asymptomatic or not unaware of having the disease and still can spread the illness. So in Singapore, they followed 7 clusters with secondary spread of 1 to 3 days prior to the symptomatic onset, and that's why it was important to know that in the pre-symptomatic stage you can be contagious, and that's the reason for social distancing. And also it's useful to know that the RO number that I just talked about, or reproductive number that is mentioned, it's not a static number, it's a dynamic number. And in China, they dropped it from 2.38 before January 23rd down to 0.99. And as you know, that their economy is opening up now. So some issues about epidemiology. This is one of the areas that is rapidly changing, and we're going to have more information as time passes. But from the earlier study from CDC of China, they put out this information on 72,000 individuals, 47% possible and 63% confirmed cases. 99% for symptomatic. So if you have the illness, most likely you will have some form of symptoms. And it was reassuring to know that less than 19 years of age accounted for less than 2%, but we know that that's different in different countries, but most epilepsy patients are younger, so that's reassuring for most families. Mild cases among the confirmed cases was 87%, so that's important to know. Either they had no or mild pneumonia. Severe with significant infiltrate or signs of respiratory complications was 14%, and also 5% had critical conditions with respiratory failure, mechanical ventilation, shock, or multi-organ failures. So this is where if someone with chronic condition can get into trouble with or epilepsy may get complicated. The first known of the case in USA was in Washington State, was on January 20th. A 35-year-old man returning from Wuhan 5 days earlier. And now, as you know, the US has surpassed all the other countries in absolute numbers. The first known case in Canada was in Toronto, again, a man returning from Wuhan, China, and that was January 27th. These are, again, just flashing areas, avenues for opportunities for treatment that I mentioned. So there are lots of promising treatment currently being studied. Now, talking a little bit about the neurological manifestation, this is one of the studies that is the largest that I'm aware of, came from China. Again, most of these studies are from China. And they looked at 214 patients over a month period. And they divided them into patients that had severe illness versus not severe illness that we just talked about, requiring intubations, and those who did not need to go to the intensive care unit. So they divided them into two groups, and severe patients tended to be older, more underlying medical conditions, including hypertension, less typical symptoms like fever or cough, and patients that had neurological complications among this group accounted for about 36%. So you can have neurological manifestations. We're more learning about this now. More severe patients tend to have neurological impairment, and the neurological symptoms that was most commonly seen were acute cerebrovascular disease or stroke, and impaired consciousness, as well as muscle injury, so direct injury to the muscle. Epilepsy was reported among the severe, only one case, so this could be just a coincidence, or still say that quite reassuring in the number of cases that was examined. This study was published on April 23rd, so it's still in its early stage. It's ahead of paper print in a journal called the Neurology, official journal of the American Academy of Neurology. The neurologists, the epileptologists around the world from all continents of the globe came together to write this consensus report for clinicians and for the patients. And the title is Keeping People with Epilepsy Safe During COVID-19 Pandemic. And one of the statements is that COVID-19 pandemic can affect everyone worldwide, so that's something that we cannot avoid, can cause additional concerns for people with chronic conditions, and individuals at risk of contracting the virus is increased with visit to the emergency room departments or hospitals, and people with epilepsy or their families and caregivers and clinicians face further consequences of the pandemic because of that. Now, the question is, are people with epilepsy at higher risk of developing COVID-19? The short answer is no, and epilepsy alone does not increase the severity of the COVID-19. There is no evidence that people with epilepsy alone have a weakened immune system, which is a main target of the disease in terms of causing severe illness. People with epilepsy should not be considered immunocompromised when they're taking regular routine seizure medication, and would not have an immune deficiency from having seizures. So that's, I think, critical. People with different types of epilepsies, certain causes of epilepsy or other health condition may have factors that affect their immune system, and I'll kind of highlight them subsequently. So some people with epilepsy, regardless of seizure control, have other health conditions. They may have diabetes, hypertension that may put them at higher risk. Some people have other neurological or developmental conditions that affect their mobility, for instance, or immune system, and they will be at higher risk of developing or expressing severe illness. And people with epilepsy may have other medical problems that could place them at higher risk of developing COVID-19. So independent medical conditions. And anti-seizure medications, do they increase the risk of COVID-19 infection? The answer is no again. The regular typical seizure medications do not increase the risk. There are certain medications in some patients with epilepsy that may affect the immune system. ACTH, that's used in infantile spasms, steroids, and some forms of autoimmune epilepsies, for instance, that are used. Everolimus, that's used in patients with tuberous sclerosis, and other forms of immunotherapy that may be necessary for epilepsy control in a specific group of patients with epilepsy syndromes might predispose them to contracting the virus in severe form. Therefore, people with epilepsy should take their anti-seizure medications regularly as prescribed by their doctors. So the question is, what should I do when if I have this virus? The important thing is call your doctor and or a local healthcare unit. If the symptoms are mild or moderate, they may ask you to stay home and self-quarantine and make sure that you eat well, sleep well, rest well to reduce the impact of the illness. It's also important to wear a mask. Now it's becoming global. I think initially there were some debates whether people should wear a mask, but now it is quite clear that wearing a mask is important for spread of the disease to others. And symptoms can sometimes be treated at home. So you may need to use over-the-counter medications. There are some concerns about the use of non-steroidal anti-inflammatories such as ibuprofen. It has not been proven, but if you're concerned about that, you may want to use acetaminophen, for instance, to deal with fever. But there are no contraindications to ibuprofen that I'm aware of. And if your symptoms do not get better or you develop shortness of breath or pain, then you call your doctor or healthcare unit. It's important that you call before you go in, because then they can make appropriate accommodations to make sure that other people do not get infected. If you live with other people, keep away from them. So keep yourself in a separate room, isolate yourself, and use different bathroom and utensils. Again, we talked about fomite transmission. If you help care for another person who is at risk of serious symptoms of COVID-19, stay away from them. That's critical. Get help from other family members, maybe volunteers that can help you out during this time. And if your seizures get worse, call your neurologist. Now, are seizures symptoms of COVID-19? The short answer is yes and no. So seizures are not typically caused or they're not the initial symptom of COVID-19, but at the very late stage of the illness, when patients develop multi-organ failures, they can develop seizures as part of the multi-organ failure. But by itself, seizure is not the typical presentation in most cases. The other condition that we certainly pay great attention to is sudden unexpected death in epilepsy. And right now, there's no evidence that this is increased by COVID-19. Just a few background about SUDEP, because it's really important that we all understand this and how to reduce the risk. It's a sudden unexpected death in epilepsy, as I mentioned. It's a sudden unexpected witnessed or unwitnessed non-traumatic, it has to be non-traumatic and non-drowning death of people with epilepsy with or without evidence of a seizure, and obviously other causes should be excluded. SUDEP is considered the leading cause of death in people with chronic refractory epilepsy. And this is a larger review that came about the prevalence of this condition and incidence, and overall it's 0.58 per 1,000 patient year, and adults is much more than the pediatric group. The relative risk is greatest for generalized tonic-clonic seizure. That's the most important factor that I wanted to get out of this slide. That's that recurrence of generalized tonic-clonic seizure is the biggest risk factor. So you want to make sure that the medications are taken regularly to avoid that. And again, this is a recommendation from American Academy of Neurology based on those reviews of the literature that the most important thing is adherence with medications and avoidance of generalized tonic-clonic seizure. So what should I do if I have COVID-19 in my community? I would say follow your local public health recommendations. Stay home. It's currently what we practice in Canada. Practice social distancing, avoid crowds, and not being too close to others. Wear a mask that I mentioned. Again, look at your seizure diary and have an action plan. You may have to modify that. Talk to your doctor about supply of medication. Make sure that you do not run out of your prescription supply and you have adequate refill. And if you can't go to your local pharmacy, I know that some pharmacies do home delivery, so you may want to look them up. Again, make sure that you have adequate supply of over-the-counter medications that we talked about that you may need for aches, pains, or fever, or nausea, things like that. And also see if you can get your food delivered either by the store or friends or volunteer. Stay in touch with your family through media, basically social media. How to protect yourself? I think the important thing is not to touch your face, because we still know that this is the most common route of infection. So wash your hands, and wash a lot each time you go out. So I think it's important to wash your hands and do not touch your face. I know it is difficult to do that, but try to discipline yourself, as well as mask maybe is also a reminder that we won't touch our face as much as we usually like to. It's also still important to make sure that you follow your flu vaccination guidelines, and you're updated with that. Avoid close contact with people who are at risk. Again, stay home. And if you're sick, call your healthcare provider. We talked about covering your face when you're coughing, and cough to your tissue or to your elbow. And again, clean and clean and clean. So back to that paper that I mentioned by neurologists around the world and epileptologists, recommendations is that administration of as much care possible. This is for the doctors. So again, keep people out of the healthcare facilities. We don't want people to go to the emergency rooms or clinics and facilities if it is not necessary. There's a chance of contracting the virus in these facilities. Again, the doctors should ensure that you have rescue medications. Again, when I see my patients through phone, that I do, and in fact, I'm going to have a clinic starting at 9 a.m. today, which will go on for the rest of the day. But I make sure that my patients have adequate supply of their rescue medication, lorazepam in particular, that we use, or midazolam in some cases. So you should have rescue medications available, and that may also avoid going to the emergency room. Minimize risk of seizure exacerbation, again, through adherence, adequate sleep, avoidance of excessive alcohol, and things like that. And again, make sure you have enough medications. We talked about that the COVID-19 does not aggravate the seizures as long as the individual is not overly anxious about their conditions, not sleep deprived, and other things. But if you do have COVID-19 where your respiratory system, your end organs, kidneys, heart are affected, so you could have complications related to that, and seizures can get worse. Or if someone has fever, like Dravet syndrome that I was talking about earlier about Charlotte, her seizures worsened because of the febrile illness, not necessarily because of the COVID-19. So does COVID-19 precipitate or aggravate, again, existing seizures? Again, I mentioned that if you are in these categories, immobile, wheelchair-bound, having respiratory conditions independent of epilepsy, diabetes, hypertension, severe heart conditions, so these can increase your risk. I did mention about ACE2. You may hear some stuff in social media about antihypertensives, because they do work on those ACE2 receptors. But it's important that people do not stop taking those medications, because there is no adequate information if those medications are protective or increase the risk of illness from COVID-19. And I know that hypertension is a risk factor, but it is premature to blame those particular drugs for this reason. Talked about tuberous sclerosis complex. If tuberous sclerosis is affecting the lungs and lung capacity has been compromised, or they are on everolimus that I mentioned earlier, the immune medication, they might be at higher risk. People who have autoimmune epilepsy and they require immune-mediated medications, steroids, whatnot, may be at higher risk. Dravet syndrome that I mentioned earlier, again, Charlotte's condition with the fever can be worsened. But the good news is that the virus is affecting children much less, at least based on the numbers so far we have from Italy and from China. The numbers are still quite low. So that is at least good that children are less affected by this condition. So in terms of non-steroidal anti-inflammatories, there are some concerns. It's not proven that should be avoided. You can still use them if needed. So if you want, you can use the Tylenol or acetaminophen to treat the fever. Some medications, even regardless of COVID-19 pandemic, we do advise people avoid them if possible. Decongestants, antihistamines that can lower seizure threshold, and that may cause more problem during this pandemic because you want to minimize the risk of having seizure and visiting the emergency room. And again, we talked about other medication, chloroquine, hydroxychloroquine, and azithromycin. These have rarely caused seizure, so it's not an absolute contraindication if you or your doctor wants to prescribe this, so there's no contraindication. But again, they are not proven therapy for COVID-19 yet, so there's something to keep in mind. If any drug is prescribed for COVID-19 treatment, it's important to check the interaction with the drug that you're already on to ensure that your seizure drugs level is not going to drop to cause more seizures or result in toxicity. So it's all about risk to benefit ratio. So I think the bottom line is that the pandemic has led to an extraordinary reduction in our healthcare availability. Attendance at medical care facilities poses additional risk of contracting the virus, and you should avoid the emergency room, clinics, and hospital as much as possible. Obviously, if there is a medical necessity, it's important also not to avoid that care. Obviously, there is heightened anxiety, and that may result also in lack of sleep, and those two factors can lower seizure threshold as well. So in this pandemic, Canadian government and in Ontario, we have switched to virtual care clinics. Physicians are reaching out to their patients by phone or through some media, which also has video capability. My clinics are done through Ontario telemedicine that are encrypted services. But the important thing is that if you need medical care, you can reach out to your doctors, and they have been made available to answer your questions, concerns, and also examine you, and even new consults also can be addressed. So I think it's just a matter of judgment if these services have to be delivered in the hospital. Otherwise, most of them can be done through virtual care. And also, if you need to have an MRI that can be arranged in 3 months or 6 months, it's best to wait if you don't have to go to the hospital. So these are challenging times. It's an alternate universe, and it's probably here to stay. I think we should have long-term plan rather than shorter plan. Virtual clinics are a reality, and we may continue using them even after pandemics is over. Lots of online learning resources, and we have come to realize how much we can get out of our technology to bring us together and also make our lives easier. There are lots of misinformation going around in media as well, so it's important to get the information from credible sources. And these are some of the useful sites that you may visit. The Epilepsy Foundation is excellent. Tuberous Sclerosis Alliance, the Epilepsy Society of UK, and our own Southwestern Ontario Epilepsy Support Centers are there for you to reach out. And I'll stop here. If you have any question, I'm happy to answer. Thank you.
Thank you so much, Dr. Mirsattari. That was very informative and gave us some amazing information about COVID-19 and how it relates to epilepsy. I do have quite a few questions that have been sent in here from our audience.
Sure.
So we will try and get through as many as possible. Are there general day-to-day health practices that people with epilepsy should be following regardless of COVID-19?
Again, it's the usual. Make sure you take your medications regularly. This is not a time to change your medications. If you don't like drug A and you wanted to switch to drug B, I would suggest that as long as things are not absolutely necessary, you may want to kind of postpone those plans. So I would say try to take what you already have, even though it's not ideal, but try to push through these times because changes in medication can be unpredictable. Make sure you have adequate supply of your medications, and know that in Ontario, all your doctors are reachable by phone. So make sure you get the health advice. Do not go to the emergency room if possible before talking to your healthcare providers.
Perfect. And my appointment with my neurologist was canceled when COVID-19 safety measures were first put in place. Is it likely I'll have to wait months for my next appointment?
Again, please reach out to the office. I'm confident that they check the messages these days regularly, and you should be able to get the adequate care. I also wanted to announce that among our own department, we have created a service called Rapid Response Team, or Neurology Rapid Response Team, which I took the call for it yesterday. We all are available to provide immediate assistance to patients that need to be seen, and we wanted to make sure that they also don't spend a lot of time in the emergency room. So we bring them to our clinic in the hospital to see them there to deliver that care. So if needed and you have to go to the hospital, we are there to reduce your stay in the emergency room in our clinic that has been shut down otherwise, and it's dedicated to seeing people during this pandemic. So reach out to your doctor. I think you should be able to get your appointment earlier. If not, contact either ask your own doctor to refer you to our urgent neurology clinic, or if you show up in the emergency room, we will see you in neurology rapid response clinic.
Awesome. Okay, and if virtual appointments are the reality, how is someone with VNS supposed to get their stimulation increased?
Good question. I think we still can provide that care in person. There are different kinds of VNS. There's some that are programmed that are automated with the new generation, but the older generation, we still need to see the patient in person. I think it's important that if it is a routine, regular increase, that you may want to kind of put that on hold for now. But if it is necessary, it's helping with your epilepsy, talk to your doctor. We can still bring you to our clinics and make those adjustments. We have reduced the number of patients we see in our clinics. For instance, yesterday that I saw patients, I was not allowed to bring more than 2 people in a given day. So we may have to look into the number of people we can bring to the clinic. That service is available. You need to make a judgment. Is it an absolute essential service that has to be modified? If the VNS is causing side effects, we don't want it to put up with it. So reach out to your epileptology doctor, neurology doctor, and find out if something needs to be done right away. That service should be available.
Great. And is there any game plan to when the epilepsy program team can start seeing outpatients at the clinic again?
These are, again, very fluid situation. They're changing day by day. We have had this conversation. We are looking into opening sometime in not far future, but we have to follow the provincial guidelines as well. So we don't have an exact date yet, but there are plans in opening. We are going to resume our first seizure clinic this week. So the first seizure, not in person, by virtual care. So the first seizure clinic will continue, and I will continue with our virtual care clinics. Hopefully that will not compromise your care, but we are looking into probably also modifying the way we'll continue with our face-to-face clinics, either reduce the numbers, but if any businesses are going to open, I think healthcare would be one of the earlier ones. So I think there's a great need to bring back patients that are waiting for pre-surgical workup, people who have finished their pre-surgical workup and waiting for their epilepsy surgery. So those will be among the earliest people that will certainly will get through the medical system once the restrictions are lifted.
Okay, great. And I'm assuming as well, when people do need to come in for emergency care, you're probably taking extra precautions like extra cleaning measures, wearing masks and gowns and all of that stuff?
Absolutely. We also make sure that the patients wear masks as well. So they will be provided a mask as well. We reduce the crowding in the waiting rooms as well. So we'll make sure that social distancing has been adhered here in our waiting areas. So those are our critical, and our trainees and ourselves, we wear gloves and masks appropriate for the condition. It's also important that we screen people, and also important for you to communicate to the triage nurse when you enter a medical facility if you have fever, if you have been in contact with someone who has had symptoms of COVID-19, so that they can triage you appropriately as well.
Okay. And what is the general consensus among the medical community around people with epilepsy getting flu shots?
Flu shot is highly recommended, so there has never been any contraindication for having flu shots. I would say that it's important to get less infection. One of the triggers of seizure is flu-like illnesses and infection and medical illness. So in fact, it's not uncommon for people with epilepsy to present to the hospital because they had a recent flu-like illnesses. Absolutely. So the recommendation is get your regular flu shots.
Great, thank you. And should I still have a rescue medication prescription if my seizures are usually under 5 minutes?
Absolutely. I think that at this point, everyone should have rescue medications handy. As you said, that we do not, excuse me, use this rescue medication for seizures that are shorter, but it is important to have it handy because it may result in avoidance of emergency room visits.
Okay. And there was a question as well about emergency room visits. So when should I take my daughter to the emergency room for a seizure during COVID-19?
Again, if your daughter has epilepsy that's well established, time the seizures. I think that's important. The important thing is that most seizures do not last more than 2 to 3 minutes. If you time the seizure, you'll realize that they're shorter. Use the rescue medications. If they return to their baseline, and they're able to breathe on their own, I would not recommend it. If there is a cluster of seizures and your daughter is not coming around, there's risk of aspiration, there's a risk of injury, fractures, then I would say that going to the emergency room makes sense.
Great. And we'll probably just go through about 2 more questions here before we wrap up. I've heard some rumblings of drug shortages. Are you aware of any at this time?
Not in particular in Canada. I know in US, levetiracetam or Keppra has been in shortage. Some pharmacies have been reducing the dispensing quantity to no more than 1 month at a time. It's really important that also people don't hoard the medications and make sure that everyone gets adequate supply of their medications. But I'm not aware of any particular drug at the moment that's on back order.
Okay, so likely the 30-day period that they're giving, that's just to prevent any shortages from happening then? Okay, wonderful. And lastly, can my increased worry and stress about COVID-19 worsen my seizures?
Yes, it can. I think it's important to know that stress, lack of sleep can worsen epilepsy. So sometimes it's not a bad idea to tune out from what's going on in the media. Maybe take a short walk, go out in your backyard and stretch, have a routine. I think those are critical to make sure that reduce the stress level.
Great. Well, we're getting close to the end of our time today, so I just wanted to say a final thank you to Dr. Mirsattari for taking the time today to share with our clients. We know that you're very busy, so we really, really appreciate it.
Thank you, and stay safe.
All right, take care. Bye, everyone.